Welcome to PharmaDocs with your host, myself, Dr. Jay Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Well, hi there, John. How are you?
Jay, hello.
Hey,
good
long time no see.
Man. Yes, sir.
Yeah.
Yes, sir. Jay, thank you so very much for this evening. I want to apologize to the Pharma Nation and to you, Jay, because I was unable to make our regularly scheduled Thursday last week. I had a daughter graduating from college, and they had multiple events and social gatherings from both Thursday as well as the graduation on Friday and Friday evening. So very special
you found out at the last minute.
Yeah, well, I found out about last minute on the Thursday evening social gathering. Okay. And so, but I do thank everybody at the Pharma Nation for understanding. Family is everything. And I hope that means also the same to all of you listening. And, but Jay and I are going to continue to bring you the great stuff on medications.
Some new drugs, 4 new drugs.
That's right.
Tonight. Hopefully we get through all 4.
I mean, look, Jay, it just never fails. I just keep telling everybody out there, whether you're a dentist or hygienist or the assistant, you got to keep up with all of this because so many people are on so many medications and it's just steadily stacking. I think we're going to blow away the average of 53 new drugs this year because, Jay, we're almost there right now.
Yeah, I have patients that come in the office daily and are on some drug that I've never heard of before. And so you gotta keep up on all these. I mean, like I said, there's 50, 70, probably even more drugs that are going to come out in 2022 that you got to know about. And this is the place to learn about them because we have the information.
Absolutely. And you can always go back to our previous webcasts and look at stuff like that. So Jay, let's just jump right on into our first one.
Sounds good.
Voquezna.
And
it's a triple pack, Jay, and it's amoxicillin, clarithromycin, and vonoprazan.
Yeah.
All right.
And so by triple pack, that doesn't mean it's 3 drugs in one capsule. It means it's a package that has 3 individual capsules in it.
Great point.
Yeah.
All right. And it's indicated for Helicobacter pylori. All right.
H. pylori,
or H. pylori infection.
Right.
And, that's the one that can infect our stomach as well as the rest of the digestive tract.
Yeah.
It's very common. About 2/3, Jay, of the world's population is infected with H. pylori.
But they're not all symptomatic.
They're not all symptomatic. That is correct.
Yeah. And this is something that is relatively new in the last 20 years. It's indicated for treatment of peptic ulcer disease, dyspepsia, peptic ulcers, gastritis. And, way back when, before I even went to dental school, I did research in the GI department at USC County Hospital. And, we treated lots of gastric ulcer disease. And the only way that it was treated was with anti-H1 and H1 antagonists.
Right.
To reduce the acid. It wasn't until a number of years later that they discovered that this H. pylori infects the stomach and it irritates the stomach lining so that the effects of the acid are much greater. And so treatment is now directed. It's not just giving an acid reducer. And this vonoprazan is an acid reducer, but it's a new kind of competitive blocker for the hydrogen potassium ATPase in the gastric cells. But you have to use it in combination. The treatment is in combination with antibiotics.
Yes.
And amoxicillin and clarithromycin are the most common antibiotics that are used in conjunction with an acid reducer to try to give some relief and actually resolution healing from peptic ulcer disease, because if this goes on chronically, patients can develop actually a gastric cancer from chronic irritation. And that's something
Jay,
we want to avoid.
Just going back before you started dental school, think about it. Okay, so you only had that one type of acid reflux drug. The protein pump inhibitors probably
we didn't even have those.
Correct.
Yeah. Well, protein pump, what's that?
Right.
They knew about it, but as far as the drugs to inhibit it, when I started dental school, they didn't exist.
Amazing.
Yeah. So, the reason, well, I guess, the reason that this company, Fathom Pharmaceuticals, came out with this new drug, in addition to getting a drug out there that they make, is that a lot of it's more powerful than other acid reducing drugs. And the
Yes.
problem has been that the drugs that have been used to date have become less effective over time because there's antibiotic resistance that's developed. Maybe the acid reducer doesn't work as well as it should, even in combination with the antibiotics. And so the success rate for treating peptic ulcer disease is not, it's not way up there. About 1 out of 4 patients who are treated for H. pylori peptic disease don't get better. Right. And so this is a drug that will hopefully work a little bit better in combination with antibiotics, with amoxicillin and clarithromycin, to bring resolution for these patients.
But Jay, what I like about it is the vancomycin, which is the potassium competitive acid blocker, or PCAB.
Yeah.
Okay.
Yeah. Yeah. And what that does, it actually makes the antibiotic more effective, because what you have to do is you have to treat the H. pylori infection. It's not just the acid. It's a multifactorial disease.
Love it.
Yeah.
And the thing about it, how is that diagnosed, Jay? How do we determine if we have H. pylori already infected in our digestive systems?
Well, there are a number of ways to do it. One is by endoscopy.
Yes.
Actually going into putting a little scope into the stomach and getting a tissue sample and see if you can culture H. pylori.
Right.
There is the the breath test, and that's
the urea breath
test.
That's right.
Yeah, and
you swallow pudding or a liquid with a chemical additive.
Yeah, or a capsule. And I think I'd much rather take a urea capsule than urea flavored pudding. So
yes. Yes.
That would be my preference there.
Then you breathe into a container, and then that sample is tested for the reaction to the chemical to confirm if you have H. pylori or not. And then, of course, the other way is a bowel movement or blood samples that can be tested for the infection as well.
Exactly. Now, there is another form of this drug, and that's the Voquezna dual pack, and that leaves out the clarithromycin. And this is for patients who are on other medications that clarithromycin, which is a very strong cytochrome P450 inhibitor, may be taking. And so they can't take the clarithromycin component. But even still, this drug does have a number of side effects. You can get obviously hypersensitivity reactions to it, especially from the amoxicillin. You can get a Stevens-Johnson type reaction, or toxic epidermal necrolysis is another side effect of this drug. C. difficile infection, Clostridium difficile infection, infectious diarrhea can be caused by putting patients on just about any antibiotic, and it could be anywhere from very mild diarrhea to being fatal.
Well, I'm glad you brought that up, because clindamycin always gets such a bad rap.
Yeah.
Because it's the one that causes PMC. No. Yeah. Other antibiotics, as you just said, can definitely lead to pseudomembranous colitis.
They all can. Yeah.
That's exactly right. So we as practitioners must be cognizant when that patient calls that afternoon. Hey, Dr. Reznick, my stomach's really upset. I'm starting to have some diarrhea. I've noticed some tinge of blood.
Yeah.
All right. So
then that's time to get them to have them go to the ER, and have them worked up for C. difficile colitis.
Correct.
Yeah.
And Jay, I want to touch base on one other thing you said about H. pylori, about not getting it treated, because it can lead to changes in the cellular lining of the stomach or the esophagus. Okay. Now, this is important. So these changes lead to what's called intestinal metaplasia.
Right.
All right. Therefore, that increases your risk of cancer, or both the stomach and the esophagus, like what you just said in the very beginning of our show.
Yeah.
So in other words, treat this serious.
Yeah.
All right.
So the cells go from being normal gastric secreting cells to cells that are more like plain epithelium.
Right. So this is typically about a 14-day treatment.
Mm-hmm.
You've got multiple medications. Don't miss it.
Yeah.
Take it as directed. I mean, you might start feeling better. Say, you know what? You know, like we've had it happen on all of our patients. We write antibiotics. Oh, I stopped it after day 3. Why? I wrote it for 7 days. I want you to take it for 7 days.
Yeah.
Okay.
That's an important point. Yeah. I go over that in detail with every patient. In fact, it says, whatever drug I prescribe, take twice a day until gone. Because you don't want them stopping short with the antibiotics, because what they're doing is they're killing the more susceptible bacteria, but the ones that are a little bit more resistant, you're letting those flourish. And
do you tell your patients
can end up being sicker?
Do you tell your patients to use probiotics?
I don't. If they ask, I say, it's not going to hurt. Go ahead and do it. I'm not really up on all the probiotic stuff. Some people swear that it's mandatory. Plenty of patients take antibiotics without probiotics and do just fine. Right. It really depends on the patient.
Well, as we know,
what their past experience is.
They are going to work on the intestinal flora.
Right.
All right. Our guts control about 70% of inflammation in our body. Okay. Yeah. I'm a huge fan of probiotics because, well, first of all, we write antibiotics for a short-term use anyway.
Yeah.
All right.
Now, what do you recommend?
Oh, I just, what has anywhere from 5 to 10 billion of lactobacillus. Okay. All right. So I asked them, and of course you have your name brands out there like Align, and then any type of generic right there. You're not going to hurt yourself taking any type of probiotic.
Yeah.
Okay.
Yeah.
And so, I mean, you can find it at Walmart, CVS, Walgreens, Sam's, whatever. They've all got their shelf probiotic. It's a great thing for the gut lining and the microbiota, or the microbiotics that are not biotics, but the
microflora,
microbe health in your gut itself.
Yeah.
So
I think it's important to have a healthy gut for sure.
Absolutely. I think we all should all be on probiotics. It's so easy to take and all that stuff as well.
Yeah. Very good. So our next drug is Camzyos, which is mevacamten capsules. And this is for hypertrophic cardiomyopathy, something that used to be called IHSS when I was in school, idiopathic hypertrophic subaortic stenosis. Because one of the hallmarks of this disorder, this cardiac disease, is that you have hypertrophy of the heart muscle. And so what happens is that it actually blocks the outflow during systole, and you get all kinds of, it causes the heart to have to work harder. You can get all kinds of symptoms it can lead to heart failure. And it's a genetic disorder. It's not something that the patient necessarily develops. It's genetic. And so in families, if you have a sibling or if you have a father, mother, child who has it, you want to get tested to see if you have the gene for this. As far as, let's say you're an adult and you have kids, this cardiomyopathy, hypertrophic cardiomyopathy, is what is the number one cause of sudden cardiac death in young, healthy teenage and young adult athletes. These athletes we hear about that just drop dead on the football field, it's generally due to a dysrhythmia that's caused by the hypertrophy, by the hypertrophy cardiac muscle.
And what's the only treatment for that?
So this Camzyos, if you happen to get to them fast enough.
That's why you need an AED everywhere you go. Right. I'm just telling you. And Jay, about that's one of those acronyms again, like we talk about IE, infective endocarditis. Same thing with, they write down HCM. All right. They may not write it underneath cardiac disease. They may just write HCM, and then don't blow that off. Ask, what is that? Oh, it's hypertrophic cardiomyopathy. Okay.
Yeah.
You have a sick patient in your office.
Yeah. And it brings up, the question, whenever a patient puts something positive down, you want to start asking 20 questions because you want to know as much about how
Yeah.
this patient is with this disease um, as you possibly can, so you know what you can do and can't do with the patient. So if they say
Right.
they have HCM and they said that's hypertrophic cardiomyopathy, you want to start asking, well, how severe is it? Do you know what your ejection fraction is? Have you had any dysrhythmic issues? And when was your last echocardiogram? When was your last EKG? And you doing some risk assessment on your patient. And I think we got to get in the habit of not just saying, okay, the patient says they have diabetes or they have asthma. We have to really go down that line of questioning until we really understand how severe the disease is in our patient and how that can impact what we're going to be doing for them.
Well, okay, so that's a great point, Jay. When you brought that up about ejection fracture, okay, so to the Pharma Nation out there, we've already talked about ejection fracture, okay?
Mm-hmm.
So
yeah.
I would hope if you have that patient that comes in, you would know to ask that question. If you don't, you do now, okay?
Right.
Because as Jay said, ask about 20 questions. Hey, have you had any chest pain? What about shortness of breath? How far can you walk? You go up the flight of steps. That's your METs.
Yeah.
All right.
Yeah.
That's your functional capacity. And we've talked about that on this show as well. And then what is your ejection fracture? All right.
Yeah.
So you need to find that out. If they say, well, I don't know. I need to know. All right. If they say, oh, it's about 37, 38, that's not a good patient to treat in your office.
Definitely not. So
we already talked about stage A, B, C, and D with heart failure.
Yeah.
Okay.
Yeah. So Camzyos, the way it's a first in class drug, the way it works is it modulates the number of myosin heads that are in the kind of the active state. And one of the things that happen with the cardiomyopathy, hypertrophic cardiomyopathy, is that not only do you get hypertrophy of the heart muscle anywhere, and it's usually in the ventricles, but you can get cross bridges that form too inside the heart, and it can affect the mitral valve. And what this drug does is it reduces the hypertrophy in the muscles, and it reduces the number of cross bridges so that the ventricle can function a little bit more normally. Now, it's interesting that the drug itself can cause a decrease in ejection fraction. So we talked about, I think a couple episodes ago, about a normal ejection fraction being from about 53 to 70%. So for this drug, it's recommended that the patient not even be started on it if they have an ejection fraction that is below 55.
Interesting.
Yeah.
And the thing about it, Jay, with HCM, if you have a parent with HCM, hypertrophic cardiomyopathy, you have a 50% chance of having the genetic mutation of this disease.
Yeah, because
that's pretty significant.
Recessive. Yeah.
Yes.
Yep. And then also the risk of heart failure on this drug increases when the patient is on a cytochrome P450 inhibitor. And so we may give the patient clarithromycin, we may give them erythromycin. That can actually throw the patient into heart failure with this drug. If they drink grapefruit juice, same thing.
Okay. Pharma Nation, what a great statement that Jay has just shared with all of us, talking about a cytochrome P450 inhibitor. Mm-hmm. Those two drugs, people still write.
Yeah.
And did you honestly know that if they're on this drug and you write that you could actually lead to an adverse drug reaction?
Yeah. Well, actually, this drug, even though it's very effective, has a very narrow margin of error. And so patients can't just go to their physician and start on it. They actually have to be in a program called the Camzyos Risk Evaluation and Mitigation Strategy program. That is at just a limited number. It's a restricted program at a limited number of facilities so they can really monitor these patients.
All right,
but it's an effective drug.
I can just see the patient coming into my office. I'm on Cammy something, and it's for my heart.
Yeah.
And they said I'm gonna be just fine.
Yeah.
You don't do that. Don't go down that pathway. But talking about what I just said about 50% of the genetic mutation. So if you have a parent with HCM, you need to be tested. Okay.
Yeah.
You need to be screened to see if you might have it as well too.
Yeah. And speaking of drugs, that brings just kind of something popped into my head. Whenever you have a patient that's coming to your office, that's a new patient, it's really important, especially if the patient is, let's say, above 45, 50 years old, especially if they're in their 70s or 80s, is you need to tell your front desk to tell the patient they need to bring in a list of all the medications they're on. Because I can't tell you how often I see a patient that comes in and we tell them this, and the patient comes in and they're on, they've got diabetes, they've got hypertension, they had a heart attack, and they don't remember the names of any of the medications they're on, and they don't have a list with them. So that medication list is really important. So please emphasize to your front desk how important it is that for new patients, that patients bring in that information. And you also want to, for recurrent patients that have been your patients for a long time, every time you see them, not just every year, but every time you see them, are you on any new medications? Do you have any changes in your health history since I saw you for that crown last month? Because it could be that they went to their doctor and they discovered they have diabetes, and now they're on an anti-diabetic drug. And you have
it's amazing, Jay. I'll have the same situation. I'll look at them. I know they're not a healthy patient. They have no medications down. I said, look, what medicines are you? Well, I didn't bring my list. Well, I can talk to you.
Go home right now and bring back that list.
I will not schedule surgery until I have that list and reviewed that list thoroughly.
Yeah, we're the same way. I'll do the consult, and then they've got to bring the list or they don't get surgery.
No. And then guess what? When they do bring that list, Jay, 20 something drugs on it.
Yeah. Yeah.
Okay.
Yep.
And now you got to go through that and say, okay, which one do we stop? Which one may you keep going with? Okay.
Yeah. Mm-hmm.
But now, Jay, some of the complications associated with HCM, it's not just cardiomyopathy. Okay.
Right.
All right. They can also have atrial fibrillation.
Yeah. Yeah. In fact, there are two types of hypertrophic cardiomyopathy. One's called obstructive and one is non-obstructive. And of course, in the obstructive, the heart has to pump harder to be able to circulate the blood. But they feel that that's not really the critical factor. The critical thing that you have to worry about with hypertrophic cardiomyopathy is the dysrhythmias that can occur in either those with obstructive or those with non-obstructive disease.
That's right. So you got to worry about AFib.
Mm-hmm.
Okay. All right.
That's the big one.
Then you got to worry about mitral valve problems as well too. You got to worry about dilated cardiomyopathy. Mm-hmm. You got to worry about heart failure, which we've already talked about with ejection fraction, and of course, sudden cardiac death.
Right.
So this is a very serious disease. Don't take it lightly on that patient.
Right.
I would do all I could for stress reduction.
Mm-hmm.
And I probably would do shortened treatment times as well too.
Yeah. Yeah. Don't try to do everything all in one day.
So, and then, Jay, how do they wind up diagnosing this? Number one, be echocardiogram. Number two, the EKG. And then number three, a cardiac MRI.
Yeah. And sometimes
I'm going to tell you something.
Jay, do a Holter monitor too. So you can look at the patient's rhythm over a 1 to 2 day period.
Now, the cardiac MRI, I will tell you this, it's about an hour and a half long procedure done with a live video of your heart. And specialized cardiologists are the ones that read it. All right. Yeah. So if you've ever had an MRI, you're going to be there a long time getting this done. All right.
Yeah. But echocardiogram is probably one of the most common ways of diagnosing it.
Yes. Now, the medications, besides just what you said, Jay, also that patients will be on too, you're looking at beta blockers.
Yeah.
All right. Metoprolol. And believe it or not, they're still using propranolol for this as well too. What's the issue with Inderol? Well, it's a non-cardioselective beta blocker. Right. All right. So we got to worry about our issue with giving a vasoconstrictor as well too, because we sure don't want to have an issue with these patients right here.
No.
calcium channel blockers, other drugs such as amiodarone, which is an antiarrhythmic drug,
Right.
A class 3, and Norpace as well too.
Yeah.
And then of course we talked about AFib. What drug comes to everybody's mind right now when you think about a patient that's on AFib? They're on a blood thinner.
Right.
Okay.
Exactly. They're usually on Coumadin or now Eliquis or
right. Some of the NOACs, the new oral anticoagulants. That's NOAC. Okay. So it could be Pradaxa, Xarelto, Eliquis, Brilinta. So it could be any of those right there as well too. So we've got a patient on multiple medications, and so you've got to work up a very good treatment plan for this patient as well too.
Yeah, know all the medications they're on and know how they interact with each other. And I if I'm not sure, I use Hippocrates and just look up the drug interaction chapter.
Yes,
very easy.
That's right.
Yeah, because we can't know everything. In fact, they taught us in medical school, you will never know everything. You can't know everything. But one of the things we want to teach you here is how and where to look it up and get the answer.
You know, Jay, they're doing some open heart surgery for this too as well, a septal myectomy. Then they're also doing the septal ablation that actually will help destroy the thickened heart muscle with alcohol. Alcohol is injected through a long type of catheter into the artery that is supplying blood to that area. All right. And then, of course, the ICD, implantable cardio defibrillator.
Yeah.
Okay. So that's planted as well, too. But
and those are for patients that have severe disease and are high risk for dysrhythmias.
So this drug is so good, Jay. Just recently at the American College of Cardiology, they said with the obstructive HCM, mavacamten improves symptoms and reduces the need for septal reduction therapy. All right.
Yeah,
so
this
is
a
unique,
good
drug.
New drug. It's not without its problems or without its issues, but it is a very good drug for a very problematic disorder.
Well, I just love our show because, again, we're introducing to so many people all these new drugs that are coming out, showing that, I mean, there is just great hope for every type of disease out there.
Yeah.
Period.
Yeah. In fact, the next drug is for a disease that you don't really hear all that much about, and that's Wilson's disease.
Right. Which is the drug is Cuvrior,
I guess.
Cuvrior.
Cuvrior, and it's a tritine tetrahydrochloride, which is a chelating agent. And so what's happening in Wilson disease is it affects the metabolism of copper. So normally, you get copper from your diet, and your liver excretes the excess copper. Well, what happens in this disease is the liver is not doing its job, and this copper accumulates in the liver, in the brain, in the skin, and it causes all kinds of problems. And sometimes it isn't diagnosed until the disease is well far along. But patients can have most of the symptoms have to do with liver issues. So like cirrhosis, hepatitis. Some of them go into just fulminant hepatic failure. They may show signs of liver failure, such as spider angiomas, erythema of their palms is another thing. Digital clubbing or blue, kind of the change in the angle on their nails and a kind of a bluish discoloration, and of course jaundice. And it can also affect the patient's brain. It can affect them psychologically. It can affect them neurologically. They may have a tremor. They may have difficulty speaking, excess saliva, ataxia, which is kind of an unsteady gait. They may just be clumsy, or they may have personality changes.
Yes.
And so there are a lot of manifestations of this accumulation of copper in the tissues. It can also affect bones and joints and cause early kind of arthropathy, or something that kind of mimics arthritis, but it's instead of being in the hands and feet, it's in some of the bigger joints.
Well, treatment is lifelong with this, Jay. And I mean, the original drug used for this was penicillamine.
Yeah.
All right.
Yeah. Which actually is related to penicillin. So if you have a patient that has a penicillin allergy, penicillamine can't be used. So So there are other drugs that they've been used. use that are the chelators, and that's kind of been the mainstay of treatment. One of the things I remember from med school is something that's pathognomonic and seen in about 90% of patients that have Wilson's disease is these Kaiser Fleischner rings. And these are from deposition of copper at the junction of the cornea and sclera in the Descemet membrane that's there. And so you actually see a ring around the cornea that's kind of anywhere from like a goldish green color. Think of, copper or oxidized copper to brown. And so that's seen in about 90% of patients that have Wilson's disease, although usually it's not till later on in the disease.
Well,
so
Jay, that wraps us up, man. We
already?
We're already. Can you believe it? And we still have another drug to talk about, and we've already had about 4 or 5 released since last week. So we'll have a great show.
All right, we'll stop here.
Thursday, June 9th.
So Vivjoa, we'll talk about that in our next episode, which is going to be on June 9th.
Yes,
June 9th, 5 o'clock Pacific time, 8 o'clock on the East Coast.
Thank y'all so very much for
thanks for joining us.
PharmaDocs. Thank you.
And we'll see you again in a couple weeks.
Thank you. Goodbye.